Acute leukemias. So there are classification schemes for acute leukemias. The first one is the French American British, or the FAB classification. It was developed in the 1970s and based primarily on a couple of different options here. So morphologic examination of the cells, which is the appearance of under the microscope, and the use of the cytochemical stains to identify those cell types. The purpose was to distinguish myeloblasts from the myeloid lineage from the lymphoblasts from the lymphoid lineage. It was also widely used before genetic testing became routine. Then we have the World Health Organization, or the WHO classification. This was introduced in 2001 and updated again in 2017. And this incorporates the recurring chromosomal and genetic lesions identified through molecular techniques. More precise classifications based on genetic abnormalities and clinical features. So diagnostic criteria include it had to have at least 20% blast in the bone marrow required to diagnose acute leukemia. This provides a more comprehensive and prognostically relevant framework. The first one we're going to talk about is acute lymphoblastic leukemia, or ALL. The incidence of ALL usually affects children or adults over 50 years of age. This accounts for approximately 25% of childhood cancers and represents about 75% of childhood leukemias. For clinical features, for B-cell acute lymphoblastic leukemia, symptoms are related mainly to bone marrow failure. So patients would feel fatigue due to anemia, have a fever caused by neutropenia and infections, and could also have mucocutaneous bleeding from thrombocytopenia. Some physical findings, they could have some swollen lymph nodes, splenomegaly, which is an enlarged spleen, or hepatomegaly, which is an enlarged liver. Some other symptoms they can also have is bone pain due to marrow expansion and infiltration of malignant lymphoblasts into various tissues. For T-cell acute lymphoblastic leukemia, this often presents with a large mass in the chest area, typically between two body cavities or organs. Some signs of bone marrow failure in this would be anemia and thrombocytopenia. You can also have organomegaly, which is enlarged organs such as liver and spleen. And they can also have bone pain from the marrow involvement. For the morphology on these lymphoblasts, we have small and large. The small lymphoblasts are about 1 to 2.5 times the size of a normal lymphocyte, whereas the larger lymphoblast is about 2 to 3 times the size of a normal lymphocyte. For the cytoplasm, it's usually a scant amount of cytoplasm, which is typically blue in color once it's stained. The cytoplasm is usually scanty and not very prominent. For nuclear features, we have small lymphoblasts and large again. The nucleus in the small lymphoblasts, so nucleoli are usually indistinct or not prominent, whereas in the larger lymphoblasts, they do tend to show the prominent nucleoli. They may display irregular in the nuclear membrane. So this morphological assessment is important in helping to differentiate lymphoblast in acute lymphoblastic leukemia diagnosis. For the prognosis on acute lymphoblastic leukemia, it's going to depend on a few things. The first one is age at time of diagnosis. So younger patients, especially children, tend to have a better prognosis. Prognosis can worsen with age. It's also going to depend on the lymphoblast load. So the number of lymphoblasts in the blood and bone marrow can impact the outcome. Immunophenotype is also going to determine the prognosis, so the specific type of lymphoblast, if it's a B cell or a T cell, and expression of the surface markers that can also help to, well, it will affect the prognosis. And then we have genetic abnormalities can also affect the prognosis, so the presence of certain chromosomal translocations or mutations can influence treatment response and prognosis. So indicators of a worse outcome, so someone who has a high lymphoblast count, so generally between 20 to 30 or more found in the peripheral blood. If they have an enlarged liver and spleen, it can indicate extensive disease infiltration. And if they have enlarged lymph nodes, it can also suggest that there's been some more widespread involvement. All right, and then we're going to move on to acute myeloid leukemia, or AML. This is the most common leukemia in adults, and incidence will increase with age. For symptoms, this is going to be once again due to bone marrow failure and disease infiltration. So they may have pallor and fatigue from anemia. They may have bruising and bleeding from thrombocytopenia. They may have a fever as well due to infection and neutropenia. They may also have DIC, which is disseminated intravascular coagulation. This is a common complication, especially in certain types of acute myeloid leukemia subtypes. They may have malignant cell infiltration, which may involve mucosal sites in skin. They may have splenomegaly, which is that enlarged spleen, which is present in about 50% of cases. They may also have tumor lysis syndrome, and this occurs due to it's a rapid breakdown of dying cancer cells during treatment. So the tumor lysis syndrome occurs when tumor cells release their contents into the bloodstream, either spontaneously or in response to treatment or therapy. Some metabolic disturbances can include acute uric acid nephropathy, which leads to renal failure, electrolyte abnormalities such as hyperkalemia, which is high potassium, hyperphosphatemia, which is high phosphate, or hyperuricemia, which is high uric acid, hyperuricorsuria, which is excess uric acid in urine, or hypocalcemia, which is low calcium. For diagnosis of acute myeloid leukemia, we would do a whole bunch of different types of tests, one of them being a CBC, or a complete blood count. Within that CBC, we would do a white blood cell count, and this could be anywhere from increased, decreased, or normal, and this is just depending on the disease stage and the subtype. Patients will generally present with anemia, and that means that they have a decreased red blood cell leading to fatigue and that pallor. Thrombocytopenia, so they have low platelet counts, which can cause bruising and bleeding. During the peripheral blood smear examination, generally there will be a presence of myeloblast, which is going to be a key finding for that. Bone marrow aspirate and biopsy will typically show a hypercellular marrow, and that's due to leukemic proliferation. Blast count is usually greater than 20%, and that's how we will confirm that diagnosis. If genetic abnormalities known to cause acute myeloid leukemia are present, the 20% blast threshold may not be required for diagnosis, and that would be because they already have the genetic phenotype, basically. For laboratory findings for acute myeloid leukemia, as mentioned earlier, we can have that hyperkalemia, that'd be elevated potassium, hyperphosphatemia would be increased phosphate, hyperuricemia, which is elevated uric acid in the blood, and that's due to rapid cell turnover. Hyperuricorsuria is excess uric acid excretion in urine. Hypocalcemia is low calcium levels, which is often secondary to phosphate imbalances. And these findings are frequently going to be associated with tumor lysis syndrome, which once again is that complication that's seen with acute myeloid leukemia during that rapid cell breakdown. Acute myeloid leukemia related changes. So incidences occurs mostly in older adults and generally is going to be associated with a poor prognosis. For laboratory features, we're going to see pancytopenia, which is a reduction in all blood cell types. Our neutrophils will show hypogranulation or hypergranulation, meaning they'll have more than 5 or less than 5 lobes. Presence of pseudo-Pelger-Hewitt cells, which is an abnormal nuclear segmentation, which we'll talk about later. And neutrophils may have unusually segmented nuclei, like we mentioned, the hyper and hypo segmented. Erythrocyte precursors could display some vacuoles, some nuclear fragmentation. They could also show immature or larger erythroid precursors. They could also show some ring sideroblasts, which is iron-laden mitochondrial, which is visible around the nucleus. Some therapy-related myeloid neoplasms in current incidence comprise 10 to 20% of your acute myeloid leukemia cases. They also have a poor prognosis, and it's associated with intensive cytotoxic treatment in patients previously treated for non-malignant disorders. For laboratory features, it's pretty much the same as the regular acute myeloid leukemia. So cytochemical stains that we use in leukemia diagnosis, the first one is myeloperoxidase, or MPO. So what it is it is a heme-containing enzyme that's present in the primary granules of granulocytic cells, including neutrophils and eosinophils, and to some extent in certain monocytes. It catalyzes the production of hypochlorous acid from hydrogen peroxide and chloride ions during the respiratory burst, contributing to microbial killing. The significance in leukemia diagnosis, so AML blasts usually contain the myeloperoxidase positive granules, so they stain stronger with that myeloperoxidase cytochemical stain. All blasts will lack myeloperoxidase activity and therefore should stain negative with the myeloperoxidase stain. So this difference helps to distinguish myeloid from lymphoid lineage when you're trying to look at acute leukemias. For staining characteristics, the myeloperoxidase stain produces a brownish or reddish granular staining within the cytoplasm of positive cells under the microscope. The next stain is Sudan black B stain. And what it is it is a lipid-soluble dye that stains phospholipids, neutral fats, and sterols within cell membranes and granules. The significance of this for leukemia diagnosis, so like myeloperoxidase, Sudan black B stains cells of the myeloid lineage, including early myeloid precursors, because these cells have abundant cytoplasmic lipids in granules. It can be more sensitive than myeloperoxidase in detecting early myeloid cells and is often used alongside myeloperoxidase for confirmation. For staining characteristics, it has positive cells will show black or dark blue cytoplasmic granules. For clinical use, it helps distinguish acute myeloid leukemia, which is going to be positive for Sudan black, from acute lymphocytic leukemia, which is going to be negative for Sudan black, particularly in cases where myeloperoxidase staining is weak or just not really working that great. The next one is esterases, and this is a non-specific esterases, which is predominantly found in monocytes and their precursors. It can also do specific esterases, which are typically found in granulocytic cells like neutrophils. So significance in leukemia diagnosis, so esterase stains are used to differentiate monocytic cells from granulocytic cells in acute leukemia. So for example, acute myeloid leukemia with monocytic differentiation will show a strong NSE positivity, while granulocytic cells will stain for SE. Staining patterns, we have monocytic cells show diffuse cytoplasmic staining, where granulocytic cells show granular cytoplasmic staining with the SE. Clinical utility is useful for subclassing the acute myeloid leukemia, especially to identify acute monocytic or myelomonocytic leukemias. These are just some examples of what the stain actually looks like. So we have myeloperoxidase, Sudan black B, and the esterase stain down there as well. And there's also a chart on there that kind of shows if they would be positive or negative based on which leukemia type you are looking at. And this is just another slide that kind of helps to differentiate between acute myeloid and acute lymphoblastic leukemia, because sometimes it's hard to determine which is which.